Good afternoon, good evening rather, and I'd like to welcome all of you to Bascom Palmer and hope you have a successful cursor. Thank you, Dr. Mello. You had a great presentation. So now my task is to try to tell you or try to help you understand the role of the microbiology laboratory in helping the physician or ophthalmologist manage ocular infections or become an expert infectologist. I'll try to do that by first giving you a brief overview of ocular microbiology and then try to highlight some points that will highlight the role of microbiology in ophthalmology and then to share some of our experience here at Bascom Palmer. Ocular microbiology is concerned with the organisms that colonize, invade, infect, and otherwise damage ocular tissues. These are long and varied and include bacteria, viruses, parasites, and fungi. Some of the most common ones of bacterial organisms include Staph aureus, Staph epidermidis, Strep pneumo, Haemophilus influenza, and Pseudomonas aeruginosus. Interestingly enough, no matter where you go in the world, these are the most common organisms. They may be different in prevalence and by region and also by age. For instance, pediatric ocular infections are probably most commonly associated with strep pneumonia or Haemophilus influenza. Some of the more common fungal pathogens that ophthalmologists encounter include Fusarium, Aspergillus, Candida albicans, and Candida parapsilosis. Again, these are worldwide, and the prevalence may be different depending on the area that you live. For instance, in the northern part of the United States, Candida is the most common fungi. In South Florida, Fusarium is the most common mold, and I think in Brazil, Fusarium species are also the most common. Some of the more common viruses are the herpes virus, which include HSV1, HSV2, cytomegalovirus, excuse me, and VZV. HIV is still a problem in some areas of the world, including some parts of the United States. The viruses are responsible for a lot of human misery and probably among the most common of ocular infections. Parasites, common parasites include acanthamoeba, which are rare but still a rather devastating organism. Microsporidia, we don't see that much here now since HIV has diminished, but in India it is an emerging pathogen, and in some other areas associated with immunocompromised or contamination with soil or water. Demodex is also, although it's a common organism that you see in blepharitis, there is some data now that's saying that it may be associated with additional microorganisms that causes blepharitis, the chronic type. And that acanthamoeba is my favorite, so I have that one. The one in the middle is Microsporidia that you can detect with gram stain. And so what the ophthalmologists are the most common ocular infections that ophthalmologists will see and have to decide whether or not they are infectious or not infectious, whether or not they need to use an antibiotic or not, include blepharitis, conjunctivitis, dacryocystitis, keratitis, and endophthalmitis. Conjunctivitis is probably the most common, and again, excuse me, occurs in children, adults, and in general, it's probably the most common presentation in ophthalmology clinics. So if you look at this, would you say it's infectious or not infectious? How would you know? Some of the most common conjunctival isolates that we see here, and again, these are the most common we see at Bascom Palmer, but if you took a survey in Brazil, Dominican Republic, you will see some of the very same organisms. Again, the frequency will be different and the order might be different. So at Bascom Palmer, gram-positive remains the most common, which ours is Staph aureus. And when you see emerging resistance among that, you can see why that would be a problem. This is followed by Haemophilus influenza and Pseudomonas aeruginosa. It does cause conjunctivitis here, probably as a secondary etiology due to medical exposure to health care. Chlamydia is still a problem here in the United States. We see it in South Florida. We have like a 5% culture positive rate, which is high. Serratia marcescens, strep pneumoniae, and adenovirus are among the most common isolates that we see here for conjunctivitis. Bacterial keratitis. Again, our most common isolates include Pseudomonas aeruginosa, Staph aureus again, Fusarium, and herpes, along with two lesser Serratia marcescens and Streptococcus viridans, which is increasing. Again, overall, though, you see that gram-negatives in Miami are the most common, followed by gram-positives, and then the fungi. Mycobacterial infections, we see quite a bit of those, increasingly associated with contact lenses, but also with trauma, but increasingly and surprisingly with contact lenses. Endophthalmitis, probably the most feared infection for ophthalmologists. Again, interesting that, you need to understand or identify the most common bacteria or organisms responsible for endophthalmitis, because in order to treat it well, you have to know what they call your enemy. So gram-positives, again, are the most common. Among these are coagulase-negative staphylococci, and for us, Staph epidermidis. There's about 29 species, and Staph epidermidis, excuse me, is the most common. 57% of all organisms are recovered from endophthalmitis isolates here are gram-positive. And you know, whether it's in Europe or Australia or Brazil, gram-positive still are the most commonly recovered bacterial from endophthalmitis isolates. And so you have to make sure if you have a therapy or want to prevent it, you have to have a drug that will be effective against gram-positives. Increasingly, we're seeing an increase in streptococci from endophthalmitis also. And so how can the microbiology laboratory help ophthalmologists successfully or more successfully manage ocular infectious disease? How can they help ophthalmologists become informed about antibiotic resistance? How can they help them develop a plan for stewardship? Well, in general, the microbiology laboratory's main role is to help you decide. You have a patient, they present, is it infectious or not infectious? We can help provide a definitive diagnosis. Sometimes you look at as a patient and you think it's herpes, or it may be acanthamoeba. You think it's bacterial and it may not be. We can help guide adequate therapy, and the microbiology laboratory can help analyze emerging trends. Interesting enough, at the Academy this year, we put a question to a group of ophthalmologists and asked them, how many of them actually perform cultures? About 80% did some type of cultures, but only about 36% or 37% actually did cultures routinely. And this is because of the emergence or the development of broad-spectrum antibiotics such as the fluoroquinolones. So instead of culturing, they treat first and culture later. Just out of interest, how many of you culture routinely? Wow. How many of you never culture? No, we're a friendly group. We're just trying to get an idea. Never culture. Is it okay? And how many culture when antibiotics fail? How many don't have access to a microbiology lab? So in general, you guys probably fall more toward not using the microbiology laboratory, right? So I have a big problem to convince you that perhaps we can help you manage your patients a little better. Well, interesting enough, when there was a study done at Baylor in 2007 to determine how accurate clinical diagnosis was versus laboratory, they found that competent ophthalmologists were able to accurately define an infectious etiology in their patients 76% of the time. Interestingly enough, they had a positive predictive value for Pseudomonas. If the patient present with an actual Pseudomonas ulcer, they were able to predict that 65% of the time. For other gram-negative for other organisms, thank you. For other bacteria, which really included gram-positive organisms, they were able to accurately predict that 48% of the time. And fungi, they were able to predict 45% of the time. They were able to predict acanthamoeba 89% of the time. That was because the patient presented at a latter stage with the ring abscess. So perhaps clinical diagnosis could need a little supplementation, as well as even if you pre-treat your patient, the laboratory has a role to help you determine if the organism is still there or if you selected the proper antibiotic. In a study that we did at Bascom Palmer in 2009, we just looked at a little more than 120 patients, and we divided them to treated versus non-treated to see if we could recover any organisms after the patient had been treated. Most of them had been on fluoroquinolones and monotherapy, and there was a culture positive rate among those who had been treated of 16% versus 34% for those who had not been treated. So what are the tools that the microbiology laboratory used to help complement clinical diagnosis? The tools include smears, which can tell you the type of microbe that's your tissue that's infecting your patient or that is causing the problem. And it can also tell you the type of inflammatory cells, whether you have a predominance of white cells or whether you see EOs on the smear or whether you see any organisms. Cultures can actually give you the definitive diagnosis. You can use a variety of cultures. You can use them to rule out bacteria, fungi, viruses, or parasites. And then once you isolate a pathogen, we'll focus mainly here on bacteria, then you can do in vitro susceptibility testing to evaluate the efficacy, in vitro efficacy of the drug. And depending on your results, you can make a recommendation to the ophthalmologist. The key, however, begins with the specimen. The specimen has to be collected from the actual source. The specimen has to be adequate, and the specimen has to be delivered to the microbiology laboratory on time. Some of the key keys are, when do you collect the specimen? You have to collect the specimen ideally before before antibiotics. But we know that happens probably at our institute very rarely, because 95% of the patient samples submitted from the our ER, the patient has been on antibiotics. So, but ideally, if you were designing your own laboratory and were giving a lecture, you would say, collect the specimen within 24 to 48 hours of symptoms. This is also true in systemic microbiology laboratories, because you want to have the organisms without any exposure to antibiotics. You want to collect it again before you administer antibiotics, because the antibiotic exposure can diminish the recovery of your microorganism. And so you would get negative cultures. You want to make sure that you collect the proper sample. We have gotten membranes or scrapings from crusted lesions, you see, where from herpes. You will not get any viruses from that. The virus is dead. If you want us to, or if you want to actually have a positive culture or a positive membrane for this, or VZ, which you see most often, you need to get where the virus is. These may be your blisters. These are usually your blisters. You have to see blisters. If your blisters have burst and dried, for instance, for herpes or VZ, then your yield will be very, very low. This is the same for if you want to rule out keratitis. You should not submit conjunctiva to rule out keratitis. The second key in making sure you have a good specimen for microbiological analysis is that you need to do direct inoculations. That means you need to collect the sample and inoculate the specimen at the bedside or in the clinic. That's because ocular samples is very, very small. You guys know that when you do scrapings, you get minuscule amounts. So instead of transferring it from your blade or your spatulas and putting it on a swab and then sending that to the laboratory, you need to inoculate your media directly, because when you do the transfer, you lose more than 50% of the sample that you have, and then in transport may kill some organisms that are susceptible to temperature and to temperatures. So you need, again, these three key points. You need to, because of the small volume, you can enhance the recovery of the organisms, especially if you plate them directly. And again, some of the fastidious organisms, such as Haemophilus, does not survive very well in transit. And Neisseria gonorrhea does not survive very well either in transit. You need to, the third key is you need to communicate with your microbiology laboratory. If you have a patient that you have an infection and you don't know what's going on, they're not responding to treatment, then you need to talk to the laboratory. Tell them, I have a patient, I want to collect, this patient has been on this antibiotic, and or I think, oh, he's a contact lens wearer, he's had trauma. What media would best be, what media do you suggest would be best for this patient? And you just need, or the physician can say, I think the patient has this. How should we handle the specimen? And the communication will enhance the recovery and improve the patient, enhance the recovery of the pathogen and also improve patient outcome. So we say microbiology or ocular microbiology is different, because the organisms that we're measuring are living, replicating organisms. And if you put them in a transport media, the organism that you're looking for may be overgrown with commensals from the lids and conch. Again, you need to talk to the microbiologist before you collect the sample, especially if it's a rare infection, or if the patient has been treated long term. In general, one of the major tools that we use are smears. And smears are prepared by collecting an adequate amount of material from the area of the ulcer, or you can use discharge to do it. But for chlamydia, for instance, and herpes, those are intercellular organisms. So you would need to have scrapings. You would need to have actual cells. So you collect the sample, you smear it thinly on a slide, and it was sent to the laboratory. We will fix it, and we do a variety of stains, anywhere from direct fluorescent stains for herpes or chlamydia, and of course we would do the mainstay, the Gram stain. The Gram stain can tell you not only what type of cells you have, what type of organisms, bacteria, but it can also detect fungi and some Acanthamoeba cysts. It takes about 5 to 10 minutes. That's total from the time you get it to the time you fix it to it's being reported. Sorry, we'll ignore it. And the specificity is about 95 to 100%. It's going to go up, I think. Okay. Some of the Gram positive is important the Gram stain is important because it will identify or separate your bacteria into Gram positive and Gram negatives. That's important because that will dictate or help you select the type of antibiotic you will give your patient. Some antibiotics are narrow spectrum and will only eradicate or only be effective against Gram positives, such as vancomycin, or some that will only be effective against Gram negatives, like polymyxin B. And there, of course, the broad spectrum group, the fluoroquinolones, which people are so fond of, that covers most Gram positives and Gram negatives. So the most common Gram positives, and what you've been hearing today, where the problem is, are Staph aureus, Gram positive cocci, strep pneumoniae, which is the one in the middle, and Bacillus species, the one on the end. P. acnes is a Gram positive rod, and it is an emerging organism in both keratitis and conjunctivitis, but we also know that it's a leading organism in chronic endophthalmitis. Gram-negative organisms, sorry, I thought Gram-negative organisms, and one that's the most common and the one that you need to know, should be most concerned about are Pseudomonas aeruginosa. Okay, and Haemophilus influenzae, Pseudomonas aeruginosa is the leading cause of keratitis in the United States, but it causes keratitis worldwide. It's most commonly associated with contact lens, but it can also cause endophthalmitis, conjunctivitis, dacryocystitis. And we're beginning to see some emergence against, that's the other one, fluoroquinolones. I thought, okay. And Neisseria gonorrhea is also a Gram-negative organism. We have, it's rarer here. We don't see so much here in South Florida, but it's about 1%. How about here? Do any of you encounter gonorrhea? You don't know. So it's a sexual transmitted disease. So Moraxella species, though, is an emerging one, and we're seeing more and more with elderly people. Moraxella catarrhalis, as well, which is used to be Neisseria catarrhalis, and of course the classic Moraxella lacunata. So those are Gram negatives, and you would want to select an antibiotic that's effective against Gram negatives or broad spectrum. The smears, just examples of the smears, Gram negatives, the the upper right is gram-negative Pseudomonas aeruginosa. Usually it comes with lots of white cells, and you aren't able to see it. So, let's see. Well, these little dots, can you see them? Those little dots are the Pseudomonas. And then your gram stain. So if you got a scraping from the physician, you did it from the cornea, you did the smear, the gram stain, you could tell him, I see gram-negative organisms, but you really can't tell him, I see Pseudomonas aeruginosa. However, if you saw the gram-positive cocci lancet shape on that smear, you could tell him, I see lancet-shaped gram-positive cocci, it's more than 90% strep pneumoniae. This is a Giemsa stain that you can use to look at both fungal or chlamydia inclusions. The Giemsa stain also can detect EOs and also any other type of inflammatory cells. And combined with the gram stain and the Giemsa stain, you could give some preliminary rapid information to the physician of what's going on with his patient. The sensitivity of the Giemsa, at least in our hands, is about 70 to 85%, but the specificity is between 95 and 100%, and the turnaround time from the time he gets into the lab to we report it to the physician is about 15 minutes. Overall, the correlation between what we see in the gram stain and what we actually grow in the lab is about greater than 90%. That is with adequate collected samples. But you can see on the pie chart that only about 62% of our organisms are considered adequate. Our smears submitted to the laboratories considered adequate. So this, for you, a clue for you is to make sure that you collect the proper type of sample for smears. We see WBCs only in about 24%, and we actually reject about 14%, send it back to say inadequate sample. So if collected properly, the gram stain can tell you quite a bit. Culturing. Culturing remains the gold standard for diagnosing and confirming ocular infections. We use a variety of media to isolate bacteria, fungi, and viruses. Since this is an anti-infective, we'll concentrate on those that we use for bacteria. The chocolate one is actually cooked blood, and this is for all fastidious organisms, but it'll grow most organisms that Staph aureus it will grow all organisms that that the blood will grow, but it would also grow Haemophilus and Neisseria. You will not get Haemophilus on blood. Well, sheep's blood. Let's go back. Oops, going back. Okay, I need to go back. Okay, you will not get. You will not be able to recover fastidious organisms like Haemophilus or Neisseria gonorrhea on the blood, on sheep's blood agar, but you may be able to do it on rabbit or horse blood, which some areas of the world use horse blood and rabbit's blood rather than sheep's blood. The blood agar plates can grow almost any organisms except the Neisseria and the Haemophilus. So if you have a blood plate and you only have you can recover bacteria and fungi there. That's not anything. Okay, and then the SAB plate is usually recovered for the recovery of fungi, both Candida and any mold. And here in this plate you see, which is very interesting depending on the scraping, is that you see in the, you might not be able to see so well, at the top rows, you'll see little fluffy edges. That's a mold. But as they dug deeper and deeper below, you see a mixed infection of a fungi, of a Candida. So overall, the routine, again, routine culture remains the standard. Our turnaround time can be anywhere from 24 hours for bacteria up to 14 days for fungi. And sometimes for fungi, it can take 3 weeks. On average, the mycobacteria may take 72 hours. Sensitivity, on our hands at least, is 60 to 90%. Specificity is about 95 to 100%. But the quality, the results is based on, you have a question? It's based on the quality and the quantity of the sample. So it's up to you. You need to submit a sufficient sample and sufficient quality, meaning from the site. In general, the setup for a conjunctivitis, we do Gram and Giemsa, chocolate and blood. And with those, the chocolate and blood, you would get the most common organisms that you saw for conjunctivitis: Strep pneumoniae, Staph aureus, and Haemophilus influenza. The Gram and Giemsa will also tell you whether it can help tell you whether it's allergic, infectious, or not infectious. If it's unusual, then we will add a DFA for chlamydia or chlamydia transport medium. For the setup we use for keratitis is Gram and Giemsa, chocolate, blood, Sabaro, and thioglycolate broth. That's our routine. So this means that we can recover bacteria and fungi on any sample, on every sample, whether or not the physician thinks that it is. But if it's unusual, or if the patient has been on chronic antibiotics or is not responding to therapy, then they might add additional media, such as an LJ, Lowenstein-Jensen media, to recover mycobacteria, or they may add a membrane for viruses, or they may add an additional plate called agar-agar for recovery of acanthamoeba. And the agar-agar is the upper here. It looks like stab. It's just plain. And you grow the acanthamoeba on it. You do your scrapings, place it in the center of the plate. You overlay it with either live or dead E. coli, and then the acanthamoeba tracks across and eats and tracks across the plate to eating the E. coli. These little packets are cysts where the organisms, where the acanthamoeba has eaten all of the E. coli, so there's no more food and they're encysting. Additional stain that you can do when the ulcer is unusual is an acid-fast stain, and you would see the mycobacteria in the smear, and you will grow. This is the Lowenstein-Jensen that you can grow the mycobacteria on. Average days for that is about 3 days. It can go to 7. And the setup for endophthalmitis, well, it depends on whether you're taking direct vitreous or direct AC. You can drop them directly onto a blood plate or a chocolate plate. And this one is showing Staph epidermidis that they just dropped on the plate. And this grows within 24 to 48 hours. But our general setup will be, again, Gram and Giemsa stains, the chocolate agar, the blood agar, and here we add an anaerobic blood agar, a Sabaro plate for fungi, the anaerobic plate to rule out P. acnes and any other anaerobe, and the thioglycolate to enhance the growth of organisms in the small sample. In general, you can recover 95% of all the bacteria and fungi pathogens on a combination of chocolate, blood, and thioglycolate, those three. But if you only have a little bit, you can use chocolate and thioglycolate. Special media, though, is required to recover mycobacterium. Again, this is our general turnaround time. For bacteria, you should be able to call the laboratory and they will give you some preliminary results within 18 to 24 hours. Fungi, 24 to 72 hours. However, there are some fungi that are slow growing, and if we put Nocardia there, that may take a little longer. We have had up to 4 weeks. Acanthamoeba, again, in our hands, usually will grow within 72 hours. We have about a quarter of them growing within 24 hours. And actually, we're beginning to see that it depends on the species and actually whether it came from a contact lens or it came from a cornea. The mycobacteria, again, because of the mycobacteria is mainly the non-tuberculous type, then they can grow. They usually grow within 3 days on blood. And what else? The microbiology laboratory can help the physician determine the proper drug, to select the proper antibiotic. But mainly, one of the main objectives or gains from having a microbiology and doing intravitreal susceptibility testing is that you can get your own local resistance patterns. Because just like your organism's frequency and patterns are different, your antibiotic susceptibility in vitro results are also different. And interesting enough, you saw Dr. Mello asked if there was any resistance to vancomycin. Here, this was even surprising to us. Our vancomycin for Staph aureus was 98%. Not that it wasn't resistant, it's intermediate. But again, one of the corollaries that he had was it's slow, and if once resistance does appear, continued use will select out the most resistant microorganisms, or will continue to select out those organisms that are either tolerant or resistant. And so we have at Bascom Palmer, at least for this data is from 2011 through June 2012, isolates of Staph aureus, they were MRSAs, that are intermediate to vancomycin. And you can see the results of the fluoroquinones. In general, as all the data that you see in the literature, all the data that Dr. Mello presented, the gram-positive organisms are less than 60%. And actually, for us, the Staph epis is less than 40%. Whereas the gram-negatives, everything is, in general, pretty good for, well, MOXIE is pretty good as for the gram-negatives, Haemophilus and Serratia. But again, as been reported in the literature, moxifloxacin perhaps is not the best fluoroquinolone for Pseudomonas aeruginosa. It is and remains Cipro. Strep pneumo, the aminoglycosides, whether it's tobramycin or gentamicin, is not effective. So gentamicin as a monotherapy would not cover your strep. However, it covers in general the Staph aureus okay, but for Staph epidermidis is less than 90%. The microbiology lab can also give you an idea of the trends that's occurring in your locale so that you can compare with what's going on nationally or internationally. This is data from Bascom Palmer, and you can see that we have had an increase, a progressively increase in MRSA. for the last 18 months, it has risen to 46%. Along with these, the MRSA, they are also resistant to the fluoroquinolones. We do have some resistant to gentamicin. And just to give you an idea, this is for a project that we did for MRSA, and we added chloramphenicol just because a lot of people outside the United States use chloramphenicol, still use chloramphenicol as an effective drug. But again, as I said, your in vitro efficacy will depend on where you are, what ocular source you're evaluating, and which drug you're evaluating. We compared MRSAs from conjunctiva, from cornea, and soft skin. The soft skin is the LEDs and samples from orbital perceptual cellulitis. And as you can see, the vancomycin, even here, there's a difference. Again, the cornea is less than the soft skin or the conjunctiva. But you can see a spectrum of differences in the susceptibility for gentamicin among the sources and also among the conjunctivas. And this is because the cornea infections tend to be more healthcare related versus conjunctiva. So you would expect any isolate from a source that's been associated with healthcare would tend to be more resistant because of the use of the exposure to more broad spectrum and more chronic antibiotics. Chronic use of antibiotics. You can also use your microbiology laboratory to evaluate new antibiotics. We did a study for Bachenome evaluating our isolates against bezifloxacin. And I think we were the first one group to do it for sources, or be able to delineate what the resistant patterns are or the susceptibility patterns are for sources. This study was accepted and pending pending publishing in the Journal of Ophthalmic and JOPT. What we found was that these were all staph epi and staph epi, both methicillin and resistant and methicillin susceptible. So as in general, bezifloxacin had the lower MICs than any of the other fluoroquinolones, but not depending on the source. For conjunctivitis, well, actually, bezifloxacin had the lowest MIC across the board compared to Moxi and Cipro. Also, there was a difference in susceptibility MICs for vancomycin. And that was, again, is reflective of healthcare. So that's another thing that you need to be aware of. If you have patients that you've been treating chronically or long-term antibiotic exposure, you should suspect that you may have some resistance. If it's a patient that's presenting with conjunctivitis acute, you think it's bacteria, they probably will not be resistant. But if you have a cornea that you've been treating over a couple of months with either even if it's fortified versus monotherapy, you would expect that organisms will be pretty resistant, or rather resistant. And again, you can see, again, depending on the source, depending on the source, you will have a different in vitro MIC. But the therapeutic outcome for is dependent on several things, as you saw from Dr. Melo. It is depending on your antibiotic. It's dependent on your patient, and it's depending on the microorganisms. How those three interact with each other and with how those three interact determines the outcome of the therapeutic, will determine the outcome of the antibiotic you choose. And so you look at the pharmacokinetics, how the drug disperses within the patient, the pharmacokinetics, how the organisms and the antibiotic interact. And then what about the patient and the microorganism? Is the patient immunocompromised, or is your ocular surface immunocompromised? Is the organisms known to be a virulent microorganism that can invade the cornea by itself, or is it an opportunist that needs some type of help by a breach in the ocular surface, or the use of steroids, or the long-term use of antibiotics? And so in summary, why microbiology? You use microbiology because the microorganisms that cause ocular infections are changing. You can use microbiology to detect the emergence of new diseases. Like you can also use microbiology to help identify the reemergence of old diseases. Microbiology can help the physician to evaluate new therapeutic agents like bezucloxacin or any other upcoming new drug, or new different combinations of drugs. This is okay. And you can also, microbiology can also be used to develop new information on familiar pathogens like Staph aureus, Staph epi. But most importantly, it can arm the ophthalmologist with information that they can become more aware of emerging pathogens, emerging antibiotic resistance, and then they can be front line for stewardship in ophthalmology. Thank you.